Good evening. Welcome to Senior Care and Lifestyles. On our show this evening, we're going to talk about palliative care. And my two guests are Dr. Frank Forti. Welcome, Dr. Forti, who's been a frequent visitor over the years. And Dr. Forti is the Director of Hospice and Palliative Care. And our newcomer is Dr. Nina Lagmani. Welcome. And Dr. Lagmani is the Associate Director of Palliative Care Medicine. Welcome to you both, and I know we're going to have a very good show. Thank you. And I'm going to start off the show asking Dr. Forti to explain exactly what palliative care is.
So very simply stated, Joan, palliative care is care that's directed at quality of life and symptom management in people with a chronic illness. So I like to think of it as I let the other doctors worry about the disease, we try to worry about the person.
Okay, well said. Now, on a previous show, you and I talked about hospice care. Mm-hmm. Can you clarify the difference between palliative care and hospice care?
Sure. Palliative care, as I said, is care directed at quality and symptom management and helping people to deal with a chronic progressive illness from the beginning to the end of that illness. Hospice actually supplies palliative care, but at the end of life, when there's no treatment directed at the disease that has any reasonable expectation of helping. So actually the government defines end-of-life care or hospice care as 6 months or less if the disease runs its normal course. Mm-hmm. But at that point in time, the total care is directed at comfort.
Okay. All right. So this is, how long has palliative care been around? It's not that long, right?
You know, if you think about what I said, palliative care has been around as long as medicine's been around. Since I think anyone who's a good doctor doesn't just look at the disease. He looks at his patient and he cares for them too. But as a specialty, actually palliative care has been recognized as a subspecialty in medicine since 2006 or 2007.
Mm-hmm. Okay, all right. Dr. Nina, are the team members specially trained for palliative care program?
Yes, so within the palliative care team, there's generally physicians, nurses, nurse practitioners, social workers, chaplain, and volunteers as well. Everybody who participates on the team has specialty training in palliative medicine.
Okay. Now, is the hospice team separate from the palliative care team?
Yes, the palliative care team, especially here on Staten Island, is localized to the hospital setting, whereas the hospice team starts in the hospital setting but extends to nursing homes and in the home setting as well.
Right. So palliative is just hospital settings?
In the hospital settings on Staten Island.
Okay.
In different parts of the country, palliative care can come to the home, but not yet on Staten Island.
Okay.
Maybe soon.
All right. That's my expectation.
Yeah.
Right. Now, who qualifies for palliative care, age-wise, stage of illness-wise?
There's no limitation. Anyone with a chronic illness that is progressive is essentially a candidate. So we take care of many different diseases. For instance, I think that when people think of palliative care, they oftentimes think of cancer care, but we take care of people with heart disease, we take care of people with kidney disease, we take care of people with blood disorders who have symptom management needs. So it's anyone, and the age range is really virtually any age.
Right. So we can include pediatrics in that.
Well, yeah, but usually we don't see pediatrics because, for several reasons, not the least of which is, thank God, pediatrics doesn't have a lot of chronic progressive illnesses.
Okay. Now, how does someone request palliative care?
Well, you know, it's, as I said, you may not need to request palliative care. Your doctor may be doing it, but if there are symptom problems that come up and the doctor is unable to to do it himself, then he oftentimes will request a palliative care consultation. Certainly families or patients can also ask for it too, and to help them to get through their illness.
Right. I would think we would rely on the physician because I think at this point in time, not many families, understand or know about palliative care. So my next question was going to be, who decides when a person needs it? The patient themselves, the family, or the physician? So generally be a physician that would
The
recommend?
answer to that question is yes. Anyone can request it.
Okay. So can someone who receives curative care receive palliative care at the same time? So for our audience to explain what curative care is.
I'll let my boss do it.
Sure. So patients that have, for example, a cancer diagnosis, if they're going to be seeking cancer-targeted treatments such as surgery, chemotherapy, radiation, absolutely they can receive palliative care at the same time. Actually, we generally suggest that they receive earlier palliative care. So when they're diagnosed with any type of aggressive illness, we usually want to get involved sooner than later. That way we can establish patients' wishes, and just to get an idea of who they are as a person, what they would like if the disease gets better or worse. So absolutely.
Okay. And where are the services provided? Like you said, basically right now it's in the hospital, but eventually it will be in the home?
That's the ultimate goal. Right now, we have a relationship with home care. So, we speak to them about patients who are receiving home care currently. And again, we have a close relationship with hospice. But we personally do not go into the home setting as of yet.
Right. And where does nursing home patients fit into that? Home side or hospital side?
Actually, there's a program that's being started throughout where palliative care, we're attempting to develop palliative care within the nursing home settings. So it's a very expansive 3-year program that's about 1 year through now, where we as a team will be hopefully educating physicians in the nursing homes throughout Staten Island in palliative care.
Okay. Because now it's just so great that hospice care, which went from the hospital to the home and now is involved in the nursing home. So I think that's been a tremendous help, patient and family-wise, when they can go to the nursing home. And of course, my sensitive question is always, what is the financial responsibility of the individual? Does insurance cover it? Medicare, Medicaid?
Yeah, actually, the hospice benefit, that when people go on to hospice, patients receive then what's called the hospice benefit for Medicare, which means that Medicare pays the hospice an amount of money per day to care and give total care for the person. In return, then, the patient's any needs the patient has related to that illness that they're on the hospice is covered by the hospice at 100%. Palliative care, on the other hand, is similar to any other subspecialty in medicine. You ask for a consultation, the physician sees the patient. Again, we accept most insurances, but it's billed directly through the insurance companies.
Okay. All right. Is there a time frame or a length of time how long someone can receive palliative care?
No, there's no time frame. Again, the earlier we get involved, generally the better. If over the course of an illness, a patient and family doesn't feel that they need too much of our services, we always just provide them with our contact information, and as things change, they're welcome to call us.
So that I have the right understanding, so when a patient is physically in the hospital, chronic illness, and it's suggested consult is put in for palliative care. That's where it takes place. So the patient goes home, right? Then the patient comes back again. Do they pick up again with palliative care?
Sometimes.
something
It depends on what they are readmitted to the hospital for. If they have pain or symptoms that, again, require our assistance, then absolutely. Or if their disease is progressing and they're becoming more ill, then yes, we get involved.
Okay. When I was working at Staten Island Hospital, we had a trend towards alternative medicine, looking holistically at the patient. Does palliative care have anything like that, or suggest, like I'm thinking about massage, yoga, meditation?
Sure. Well, that's why palliative care, it's really a team approach. So the social workers that are on our team, they provide supportive counseling. We look to seek, complementary type of therapies depending on what the patient responds to. Guided imagery, music therapy, things like that are things that we are going to be introducing shortly. But yes, it's a team approach, and that covers that as well.
Yeah. Okay. Now, you did say that in some of the other boroughs, they do palliative care at home. Right, okay. I don't know if you can answer this question, but I have two friends that go to Manhattan for care. Would they go from one borough to the other, if you know that answer? Like if she receives palliative care, like say at Mount Sinai, and she asks for that to continue, would they cross the borough line?
Sure. I mean, we are in communication with every hospital that is caring for the patient. So whether they prefer to be here or there, it really doesn't matter. It's patient preference, wherever they're more comfortable, what's geographically more convenient for them and their families.
Okay. You and I talked a little bit about, I asked, was it possible to know how many patients have received palliative care, which is a big number. But you spoke about, you're more in line with how many consults you did.
Well, because again, the palliative care per se is a consult service for the most part. We follow those patients. But I think the important thing, because as you alluded, a lot of people don't know what palliative care is. So historically, I mean, I've been doing strictly palliative care as a clinical practice for the last 14 years. But as I said, it's only been recognized as a specialty for the last 9 or 10 years. But when I started doing this, I was the team, so to speak. There was no one else. And it's only in the last 2 years plus that Dr. Lugmani and 2 social workers, 2 full-time nurses, now a nurse practitioner. So the team was created and is being increased daily. So the only way that we can tell is by new patients whom we see.
Right.
And we have been increasing the number, which means the awareness is there greater and greater by probably 20 to 30% a year over the past 10 years.
So you gave me a rough estimate, rough number for the past year.
Yeah, I can tell you that in the hospital setting, we saw over 800 consultations over the last year. What we've done too, just if I may, is we also have put a big push on to make sure that people who are in the critical care units, like intensive care, that the nurses there are very attuned to not only the treatments directed at the disease, but caring for the patients. And so we've been getting a lot of consultations from the intensive care units too.
Right. I can speak to the fact when it was just hospice care available, all the nurses know about hospice care. Obviously, they all know. But there was always like a little line drawn there where we couldn't feel comfortable freely saying to the family, would you like to see someone from hospice care? And they usually left that up to the physician, not on purpose, but we just felt we couldn't take that step forward. But with palliative care, I think maybe that's a little bit different now. I think the nurses probably will feel more comfortable saying it's palliative care because it's not an end-of-life issue.
No, again, palliative care is complementary. I mean, we don't take over care of the patients.
Right.
We work with the patient's physician who's taking care of their illness to help the patient. Whereas hospice is at a point in time when there is no care directed at the disease that is going to help. So at that point in time, then it's really not as inclusionary as palliative care.
Right. Even though we're talking about chronic illness, with hospice, there are certain stipulations, right? Yes, 180 days probably before the end of life, not to take chemo or radiation, right?
No, not necessarily.
Yeah.
I think 6 months is an estimate of
Right.
survival. And so the government had to say some number, so that's the number that they picked. From the point of view of treatments, it's almost invariably patients where the treatment that's available is palliative. It's to help the patient through his disease. And so, as I said, usually there is no disease-directed care that's going to make the patient better when the patient's on hospice. So one can do things for a patient just because it would help them symptomatically. For instance, if somebody is symptomatic because they have a bad anemia, they would transfuse him. They wouldn't transfuse him just because of a number, but because it would help him symptomatically. It would help him to live a better life.
Right.
So that's what's really looked
Right.
at.
That's kind of falling back on the question about curative care. So if you're on palliative care, you can have any means that's going to make you feel better and have a better quality of life.
Sure.
Right. Okay. So an issue is getting the information out to the public. That's an issue. And I usually say on this show, the purpose of Senior Care and Lifestyles is to educate the public and pass on the information. How do you get the information out to, well, for hospital-wise, of course, you have, the staff and you have the educational part of that where they're informed about palliative care. Do you go further than that outside the hospital for education?
Dr. Forty especially, he does.
Yeah. Yeah, we're here.
And this is a good place to be.
Yes, you're right. So, but I have been lecturing to the house staff. I was going to downstate since I've had my surgery. I've had to limit that, but I was going to downstate to teach the medical students about palliative care, and we oftentimes have dealings with the community talking about it too. So it's something that education is one of the major things, because physicians, if you think about it, physicians were brought up to learn about diseases, and oftentimes the patient with the disease is sort of in the background, and that's one of the things when I try teaching the students and the residents that I always push is, you're not treating diseases, you're treating people with diseases, and they're all different.
I became a nurse a long time ago, and that's the way that I was taught. I graduated from St. Vincent's School of Nursing on Staten Island, and we were educated right from the hospital itself. That was our whole time in school, was in the hospital. We left one time to do specialty in psych. And that is the way that the nuns taught us. And we did have a few physicians, but mostly nuns taught all the subjects. And that's how we were taught. I guess we were doing holistic nursing before the term became popular. And we were taught to take care of the whole patient, and that extended that ripple effect to the family. So it sounds like, from what I'm reading, what I read about palliative care, it's involving everyone that's important to the patient. Yes?
Yes.
Okay.
Yeah, I think as you mentioned, the hospice and palliative care, the unit of care isn't the patient. It's the patient and the family, because the family is oftentimes in as much distress as the patient is.
Absolutely. What we find sometimes in nursing is when the family is approached, I'm just comparing hospice and palliative all the way through. When they're approached, the family is approached, sometimes they're very hesitant. No, I don't want him to have hospice, or no, we're not ready for it. Do you have that kind of a problem when you do consults with palliative care?
Sure, there are times where families are very guarded. You know, everybody's hopeful that their loved one is going to recover. But it's amazing to watch the sense of relief that people feel when you talk to them about what their options are. Because sometimes as doctors, we're obsessed with technology, and we want to just keep going and going and going, and sometimes at the expense of a patient's suffering. So when a family hears, you know, we cannot do certain things, it's amazing to see just the relief and the peace that comes to them when you start talking about these things. But, you know, we see both sides, and we work with it either way.
Right, right. Just sometimes they take that risk and just listen to what you have to say, because sometimes they'll have a misconception, somebody won't explain palliative care correctly, and I'm sure they're going to hook it up with, oh, this can't be good, right? When you do a consult for the palliative care, do you talk about the quality of life?
Absolutely.
Because this is a very common phrase that we use today, and I would like our audience to understand when we talk about quality of life. What are we talking about?
So when somebody unfortunately has such a debilitating illness, what we talk about is what is an acceptable living for them. Is being completely bedbound and being kept alive on machines acceptable? Is losing a leg acceptable? You know, what's acceptable is different per person, per family. So when we talk about quality of life, we're talking about what does the person find important. You know, very vibrant people generally would never, ever, ever want to live confined into a hospital if they're at end of life, really. And so we try to focus on exactly that. What are patients' preferences? What do they see is a quality of life and what is not? And then try to guide their care according to that conversation.
My mother and father both passed away within the last 3 years, and they thank you. And they both had very opposite views on the quality of life. And I always, the whole marriage for 67 years was oil and vinegar, but they were together forever. And my father was very definite, very well-read, educated man, and he said, listen, my quality of life is going to stop if I can't function 100%.
Exactly.
So, of course, we respected that, DNR and all that. My mother, the total opposite. I don't care what you have to do. I made her do the DNR just in case. They were both healthy. And she goes, I want the vent, I want hemo, I want blood. She wanted everything. And that's two extremes, you know, but that's how they were their whole life.
Yeah.
But so I just wanted to talk about some of the terms that we use in the hospital all the time, you know, and hope that the audience is familiar with it.
Sure.
You know, and sometimes we forget that, right, Dr. Forty?
Oh, yeah. and I think one of the major problems, pardon me, is that when you talk to patients, oftentimes they will tell you that they didn't understand, or that doctors are saying different things because they're talking with doctor language, which oftentimes, you know, we use so many words and that you get used to it, and unfortunately people don't remember. For instance, H&P is very common, and I'm sure most people today know that means to examine a patient, a history and physical, but some people have no idea what you're talking about.
Right. The common sign that you see up all the time over the patient's bed, NPO.
Yeah, right.
You know, nothing by mouth.
Right.
Even with the nurses, they are totally guilty. We're just so familiar with the language and the abbreviations that it makes it a little bit difficult for the patients. And my whole nursing career, Dr. Forty can testify, when a doctor goes in to tell a patient anything important, if it's my patient, I'm right behind them because I know that patient is not going to have 100% understanding.
Yep.
So the nurse goes in and just interprets what the doctor says. But I do find when I'm dealing with the newer residents and newer attendings in the ER, I do see them taking the time to explain on the patient's level. You know, this is the test we're going to do, and this is why we're going to do it. I do see a difference. It wasn't like that years ago. Are you going to go for a CAT scan? Oh, well, what CAT scan of what? What is a CAT scan?
Yeah, but I think generalizing is always a bad thing, though.
Well,
So, they said all generalizations are false, including this one.
oh, no, I have a lot of experience there, so it's like 3 minutes left. But, I mean, that's a lot of nurses do that after the physician finishes talking to them, especially pre-op,
Yeah.
okay? And the patient's nervous. The family's nervous.
Yeah.
So you always hope that there's an extra pair of ears standing there listening. And I'm sure that when you go and you talk to them with your consult about palliative care, if the patient's by themselves, it's when the family comes in, oh, somebody was here. And I noticed that a lot of physicians, nurses, social workers, they're all now leaving their card, so it makes it a little bit easier for the patient to remember. Oh, Dr. Forty was in, and he has palliative care, and it makes it easier, I think, for the patient to remember and for the family to find you. I think that's very helpful.
Sure.
So we have like 2 minutes left. I want to just ask you, is there anything else that we can do to get the word out there about palliative care? Anything that we're not doing, nurse-wise, or?
I think the only thing that happens is that people sometimes think of palliative care and hospice as an end-of-life type issue, but it's not.
It's
I mean,
not.
it's an issue of helping people to live. As I said, palliative care works with the attending physician. We want people to get better and live a normal life. But we also want people to understand and to be able to honor their wishes, too. Oftentimes, I think we're stuck in a situation where the way we've presented a particular item doesn't present both sides of the coin equally, only because we think about the importance of doing oftentimes rather than not doing.
So I would like to just say that palliative care is more on the upbeat side of the coin,
Oh, certainly.
right? Because you're looking towards the future. You're not afraid of the future. You're looking towards the future, and with help and assistance, and to enjoy that better quality of life.
Yeah, I think if you look at it, no matter how many days I have, whether it's 1 or 10 or 100 or 1,000 or 1,000,000, I want to live the best life I can for that time. And that's really what it's all about. It's living the best life you can.
Okay, and we just lived through 30 minutes of excellent information out there for our audience. So I want to thank Dr. Forty, and I want to
pleasure.
thank Dr. Nina. And to our audience, thank you and good night.